right. Wow, it's hard to believe. We did it. We are remote.
We are.
We have got Dr. Segal from Maine and the country doc, myself here in Plattsburgh, New York.
I'm in Portland, Maine.
Wow.
Where it's currently raining. And I have been here a month, Craig.
I know. It's fantastic. We've caught up, and I can't believe the cases that both of us have seen in the last month. It's like nothing was very interesting lately. In the last 20 years of practice, I've had no interesting cases. And then it was like, as soon as we did the podcast, all of a sudden I had a wink disorder. I had like I had a sodium of 104 in a new onset end stage patient. Classic cases.
Yeah, no, these were good. Great. And you even said that you referred back to the podcast for some.
I keep going back to the podcast. I love them. They're like my new reference.
Right, and I would say that interestingly, since I've been here in a month, I've seen almost every different version of hypotonicity and hyponatremia, including cortisol deficiency. And I've seen more cases of rhabdo causing AKI in a month than I usually do in a year.
That's amazing. I love it.
It's really good. And the food and the people and the everything is great here.
That is excellent. I'm looking forward to coming up there to see some music with you up there.
Oh yeah, man.
Yeah, you got some good shows.
And so you figured out, the technical expert that you are, figured out a way to make this work remotely so that we have a great audio and video.
The only thing that I'm going to miss is being able to go out for dinner afterwards.
Yeah, I know. Well,
Dina said, and Dina forgot. So Dina was like, "Oh, you're going to podcast with Alan. Where are we going for dinner tonight?" And I had to tell her, he's still in Maine.
Well,
it's remote.
But when you come to Maine, there's no shortage of great places to make up for it.
That is for sure. All right, so we have an awesome talk by you today. So I'm looking forward.
Yeah. So here's our title slide with our 2 kidney guys in the flow state. We did 9 in person. And today is number 10.
Yeah.
And our topic today, which loops back at a couple of things we've already talked about concept-wise, is polyuria and diabetes insipidus. And we talked about, that there's 2 diabetes, mellitus and insipidus, of course, is when it's a large flow of tasteless, not sweet urine.
Mm-hmm.
So here is our control system of the day. And I'll talk about that in more detail. Because what this is one of our classic negative feedback control systems. So in this particular case, the thing that's being controlled is body tonicity. And so on the right, you see it says the controlled parameter is body tonicity, and the players or the effectors is thirst, ADH secretion, and aquaporin 2 water channels. So in the feedback system, the thing that's being detected by the sensor is the difference between where the body tonicity is and where you want the body tonicity to be. Right. So let's say somebody, like a kid or a tennis player, plays hard and they sweat. And sweat is mostly water, so it's a hypotonic loss. And if a hypotonic loss results in hypertonicity of what's left behind. So that's going to drive the error signal to be less than 0, and that's going to drive the system. That's going to stimulate ADH release from the posterior pituitary, and that actually comes before thirst. So 2 things happen when plasma tonicity goes up. ADH is going to be released, and you're going to get thirsty. But a lot of people think thirst comes first. It actually doesn't. And physiologically, this makes sense because you wouldn't want to drink the water. You wouldn't want to put water in a cup with holes in it.
Right.
So first you arrange for the reabsorption and the retention of the water, and then you drink the water.
Right. So
then you drink and retain the water, and this brings your tonicity back to where you want to be. And, this is automatic and very good system. So we don't worry about our kids when they go on the playground and sweat. They play and they go, and what do? When they lose water, when they lose free water, there's usually on the playground a free water fountain where there's water for free. Okay, so they're getting free water for free. And so this is the control system. And the thing about it is, like you get disease when the control system doesn't work. So it would certainly be very bad if you couldn't sense thirst. That would be life-threatening. It would be bad, but not life-threatening if you couldn't secrete ADH, and it would be bad, but not life-threatening if you couldn't make water channels. And all these things happen.
Or if you perturb the system, like this is another one of those endocrinopathies. And I thought about this with any endocrinopathy where there's primary versus secondary. Primary causes where there's a disease in the control system, and secondary where something else is causing a problem, but your control system for that particular for tonicity is intact.
Well, I mean, I'm not sure. I hear what you're saying, though. I'm not sure that I look at it that way. I mean, for me, primary means the organ itself has got a problem. So if you've got a thyroid problem, it's primary if the thyroid tissue is the problem. It's secondary if the TSH from the pituitary is the problem.
But I'm thinking like, well, we can get into it as we go through the disorders, but okay.
Yeah, but I mean, that's how I think of it. But anyway, here's the classic slide from the comprehensive nephrology textbook about how the brain and the kidney team up to keep tonicity convenient and good. The thirst and the osmosensing parts of the brain are close together, but they're not identical. And with this slide is nice because what it shows is as the green line here is the ADH release graphed along the left axis. And then what you can see in yellow here or gold is that what happens to urine osm. So as you know, here's the normal tonicity of, let's say, 280. Below that, you shouldn't get any ADH secretion. And if you do, you're going to have SIADH, and we'll talk about that in the future. And you're not thirsty. You're far from thirsty because you're, if anything, overhydrated here. Now, as you start to lose water and tonicity goes up, so does right away, as soon as you go above target, your ADH level goes up. And as soon as that happens, you see the urine osm going up because water is being removed from the tubule, being put back into the blood. And then it really is far along until you get thirsty. You got to be up toward, 290 here. But ADH is going to be active below 290. So just remember that that ADH is in control first, and then that's retaining the water. And then if you need to drink additional water, that's when thirst comes in and you drink the water.
So thirst is really at the further end. It's already when you're at the upper normal range of tonicity.
Right. So thirst, there's two things to say about thirst. Number one, it's the ultimate defense against hypertonicity. Without thirst, if you can't sense thirst, you're in real trouble. That being said, it's the ultimate defense, meaning like a safety in a football game. You don't get to that first. So it's ultimate, but isn't first. Because you got ADH, supposedly, you want to, the physiological strategy is retain the water we have, because it's going to be work. It's going to take us away from what we're doing to go get new water. So first, retain what we have. And if that's not enough, then go get some.
And I think in the setting of where polycystic can be driven by ADH secretion, that by the time you get thirsty, there's a lot of ADH around. I guess that was what I was thinking about when I was looking at this in that setting.
Right. And also, it's also why treating polycystic kidney disease with water drinking is very difficult. It's very difficult to get to keep your ADH level that low.
Because you hate water when you're low like that.
Yeah, it's really hard to do.
Yeah,
to suppress it to zero.
Interesting.
Okay,
cool.
So here are the players: the brain, thirst, where the brain is the part of the body where there's thirst sensing and osmosensors that basically act in response to changes in cell volume. So when there's water loss from the body, all the cells will shrink, including the osmosensors, and the shrinking of the osmosensors is the thing that is the signal to get going. So thirst is the ultimate defense against hypertonicity. Arginine vasopressin, or AVP or ADH, is secreted from the posterior pituitary when the time is right. And if you don't have the ability to make enough ADH or any ADH, you'll have what's called neurogenic or central diabetes insipidus. You'll lose all the water because you don't have ADH. We'll show you cases of that.
And just going back, because you have the physiology and the anatomy lays out here nicely, the brain part of it, that's the hypothalamus where the osmosensors are.
Right. It's the hypothalamus, and in adjoining areas close by but not identical is the thirst sensing.
And the thing is that those are connected by that hypophyseal tract that goes through there, the supraoptic.
Yes, there's fibers that connect all of them.
Cool.
Because they're in a concerted system to work together, like us. So then, of course, it's not enough just to secrete ADH. It has to find its receptor. And again, in another beautiful part of physiology, the receptor is on the basolateral membrane of the principal cells. but the channels themselves that are stimulated by the hormone and receptor are on the apical membrane. So the signaling starts off basolateral, then goes through the cell to become the water channels inserted apically.
So the apical membrane is the one that can change its water permeability, but the basolateral membrane always has water permeability.
That's right. And so we'll talk about the mutations of these, but as always, you anticipate the next slide. And the slide is that here's principal cells in the collecting duct. And so so the collecting duct on the basolateral side has aquaporin 3 and aquaporin 4,
right,
which are always open. So they're constitutively active. They don't control the gate. What controls the gate is when AVP is not bound, then the water channels, the aquaporins, stay in subapical vesicles. They just stay there. When AVP binds, the signaling through G proteins and adenylase cyclase is such that using microtubules and a lot of very complex and elegant signaling.
Lots of phosphorylations happening there.
Phosphorylations happen and other things happen that cause these vesicles that are sitting just under the membrane, to fuse with the membrane. And all of a sudden, so this apical membrane can go from having no water permeability, like the thick ascending limb, to having a big water permeability when these vesicles fuse.
Even after 40 years. Well, those vesicles just sit there.
You're gonna see that is, we talked about that patient, and we're gonna talk about her again today.
Beautiful.
So here's an interesting thing, and one of my favorite things, of course, back from my day, and it brings into our region. Let me just tell you quickly the story about what became known as the Brattleboro rat. So the Brattleboro rat, there was a professor in St. Louis of chemistry who was sick and moved to Vermont. He moved to West Brattleboro, Vermont, to retire, but he still wanted to do some chemistry experiments. He's like us, he wanted to keep
Couldn't stop. It's like you with your patch clamping. How many patch clamp amplifiers do you have in that place up there in Maine?
10.
Oh, jeez.
But one of them but two of them are doubles.
Exactly.
So I can
dual
make,
patch.
I can make 12 patches at once.
I love it.
So,
That's awesome.
So he moves to West Brattleboro for his health, but he brings his rats and he's doing some chemistry experiments, and he hires a guy to help him take care of the rats. And what happens one day is the helper guy, who's changing the bedding in the rat houses, comes and tells the professor guy, "Hey man, in cage 17, cage 17 or something like that, I have to change the bedding in there like constantly. These rats won't stop making urine, and they're always out of water." So what this professor did, he had two choices being down in Brattleboro. He could have gone up to talk to the renal people at UVM, or he could have go to Dartmouth. And what he decided to do is he decided to go to Dartmouth. So he meets up with Heinz Valton at Dartmouth, who is an excellent renal physiologist. And he tells Heinz, "Hey, there's something going on with these rats." Well, long story short is that through elegant work, Heinz Valton and his associates figured out that the problem with these rats was they were making, and this is a poster that hangs at Dartmouth, this is a Brattleboro rat next to a beaker of its daily urine output. Now, that may not look like a lot, but for a rat, that's its weight in urine. That's a lot of urine. And it was found out that basically this was an experiment of nature. This rat, for whatever reason, was born with the inability to make ADH, and they had complete central DI. And that was very important discovery, because for people doing water studies, water metabolism studies, this was in 1961 that the rats were born. And this has been a very useful research model for people studying water. Here's the original paper, Craig.
Cool.
You see, this is Heinz Valton and the professor from St. Louis. And this appeared in the American Journal of Physiology in 1964. It's a landmark paper. So again, you see the rats were born February 24th, 1961. The paper was published in 1964. And here's the key result. Normal rats are in the open bars, and the Brattleboro rats are in the hatch bars. So here's the water that a normal rat drinks a day, and here's the water that these rats were drinking. So they definitely had polydipsia.
Right.
But they didn't have psychogenic polydipsia, not that the rats were, having psychiatric disease. So again, the normal rats drank a little bit of water, peed out less because they used it, whereas
they were able to have very concentrated urine.
Yes, these rats have a huge amount of unconcentrated urine.
Right.
Okay. So look at the urinosum. So the urinosum of the normal rats, 1793. That's
amazing.
Pretty good. Yeah.
What a medulla. Those guys.
Yeah.
Have.
What a countercurrent.
What
exchange.
A countercurrent exchange they have.
Please see our previous podcast.
Yes.
But then look at this. These rats have to make up for this defect.
Right.
Being not able to concentrate urine and only make a dilute urine.
Right.
They have to get rid of all this urine. So this is a classic. I love this slide.
It's amazing.
I mean, I don't know where you are. I don't know where people can be without knowing the history of these things, because this is beautiful. And then,
story.
Years later, when we came up with tolvaptan, now there was no tolvaptan. There was no blocker of the V2 receptor. So basically, tolvaptan that came along, so the Brattleboro rats were early 1960s. Tolvaptan was the 2010s. That much time for a drug to basically make Brattleboro rats retire.
Right.
So the hardworking Brattleboro rats could retire now because we've got tolvaptan that causes not central DI, but basically blocks the V2 receptor.
Cool.
So a quote from this paper: there is a need for another reliable experimental model beside the Brattleboro rat to investigate V2 receptor mediated vasopressin actions in the kidney. Now, Craig, when you moved to Vermont to be an intern, were you aware of the town of Brattleboro, and were you aware of the Brattleboro rat?
I was aware of Brattleboro, but not the rat.
Now, during your fellowship, did you become aware of the rat?
I'm sure in my time with you exposed me to it, but I don't specifically remember the Brattleboro rat.
So one of the first things I did when we moved to Vermont, people said, "Well, did you?"
You went
to
Brattleboro.
Did you? I said people said the first thing you did was probably go skiing or eat Ben and Jerry's.
Not Alan Segal.
The first thing I did was go to Brattleboro to see the rat.
I love it.
Yeah, and by the way, Brattleboro rats are very frustrated because Brattleboro itself has some excellent breweries. But when these rats go out to the breweries, they just cannot sit there and drink a beer without having to go to the bathroom.
That's it.
That's why you see less Brattleboro rats in the bars. All right. Can you imagine having DI and going to a bar? It would be horrible.
A nightmare.
Okay. So let's get into the topic now. So that's kind of some highlights of history and everything. Cool. Let's talk about just what this thing called polyuria. So polyuria means many urines, or it means it's a weird word. I don't think it's not the greatest word, but it means you make a lot of urine. So as we talked about early on, a normal person makes about 1 milliliter of urine per minute. 1,440 minutes in a day is just about 1.5 liters of urine a day. So we define clinically. Now, Craig, in your clinical practice as a country doctor, when you get called, what do you tell your trainees and your colleagues constitutes polyuria? This is our working definition.
Yeah,
what's yours?
That's about it. People making more than 3 liters in a day is a lot of urine, and depends on their size too, but roughly that's about where we're at.
And this is the amount of urine we tell PKD patients they should try to make.
Right.
Okay. So the differential diagnosis of making a lot of urine is you could be drinking a lot of water. And as we've talked about, the best, if a diuretic is something that causes you to make urine, water is the best one. So you really have to know. I mean, it's not a surprise to find that someone who's drinking a lot makes a lot of urine.
Yeah.
But that's what I call, you'll see that I call that push polyuria, because you're pushing it out. And then there's things like osmotic diuresis caused by excess solute being in the urine, dragging water out, as in glycosuria of hyperglycemia, DKA, or hyperosmolar non-ketotic state. Then, people who have obstruction and their BUN builds up. BUN normally is not an effective osm, but when it's really built up and flowing fast after you relieve the obstruction, it will drag out. There'll be so much of it that the urea transporters, which are probably still sick, can't keep up. So BUN, blood urea nitrogen, will act as an osmotic diuretic when it's flowing in a high concentration with a lot of flow and the kidneys damaged, just getting over damage. So you've seen this. Do you see this every now and again?
Post-obstructive diuresis? Yeah, seen that. Yep.
Okay. And then we'll talk about other
And then sometimes we think it's appropriate because a lot of times those people are volume overloaded. So some people get confused between them appropriately getting rid of extra volume versus, a true osmotic diuresis from the high BUN.
Right. Well, a true one, yeah. And so these are only a problem. I mean, there's nothing wrong with urine coming out. It's the body that we're concentrated on, but this is a problem when this leads. See,
to hypertonicity.
The kidney is supposed to keep you in isotonic state.
Right.
If the kidney is forced to do something that's compromising that's a problem. And then here's our diabetes insipiduses. And there's, depending on who you are, there's a couple. There's the dipsogenic, which is really the psychogenic polydipsic. It's not really DI, it's just drinking a lot. Then there's the central DI and the nephrogenic DI that we're going to talk about. And then there's a very interesting gestational DI. Craig, I don't know, have you ever been pregnant?
I've never been pregnant.
Really?
I've been close to pregnant people before, though.
Well, Craig, you've got kids.
I do have kids.
Did you make your wife do all that work?
She did everything. She's amazing. I am the luckiest guy. You know that.
But Craig, isn't it fair to at least do one
share
of the 3 kids?
Something? Yeah, if I could, it would. Here at this point, this is where I was talking about, like, thinking primary, where there's a defect in the control system. If you look at these 4 things you have listed under diabetes insipidus, dipsogenic would be there's no problem with the control system.
No, there's a problem in the brain telling the person to drink.
Exactly. But not from the osmoreceptors, from the hypothalamus through the entire signaling system, everything in our control system, no problem. Neurogenic, problem. Nephrogenic, problem. Gestational diabetes insipidus, no problem. You have excess vasopressinase, but there's no problem in terms of the person's signaling of the control system.
Yeah, it's basically kind of a reset.
Yes,
it's
exactly.
Sort of the opposite of a reset because and it's not going to get reset very much because they're just going to drink the water.
That's a very cool one. I mean, pregnancy is unbelievable.
Pregnancy is unbelievable, and pregnancy has
men
effects.
Couldn't do that. Men, we can't do that.
We're pathetic.
We don't even have vasopressinase.
We don't even have anything. Listen, now here's the thing. As we'll talk about when we do ADH in the future, there is a shift. Pregnant women seem to have a shift to become a little bit on the hypotonic side. So I always wondered, is the gestational placental vasopressinase kind of that it would in a way give them a partial central DI? Mm-hmm. Is that sort of to balance off the tendency to be hypotonic with their kind of resetting of their ADH? I don't know, but there's usually, nature has good reasons.
There's a reason for them to put the brake on that system for sure.
Maybe the reason is early on, it was a stimulus for pregnant people to always be near water, meaning that if you're near water, stay close to home. You're pregnant. Mm-hmm. I mean, if I was pregnant, I would just call into work every day and say, I can't come in. I have a vasopressinase going on.
I have excess vasopressinase.
Excess vasopressinase
syndrome.
Yeah, and I would be too much of a
acquired partial central DI. They would understand that. You just put that on your FEMLA form.
That would be my billing code, right?
That's it.
So those are the polyurias. Okay. So if you look now at the key is, and you pointed out that polydipsia is there's a problem with behavior, but there isn't a underlying lesion in the brain or the kidney. But the important thing is, as clinicians, it's vital and crucial that we never confuse, that we always make the diagnosis of whether somebody's drinking is coming from them or coming from a DI, because the treatment is different and it's dangerous. The treatment for one is dangerous if you give it to the other. So both primary polydipsia and diabetes insipidus result in polyuria. So polyuria is the common denominator.
Exactly.
And as I said, primary polyuria or psychogenic, primary polydipsia or psychogenic gives you push polyuria because you're drinking a lot. Whereas DI is pull polydipsia. You're drinking a lot because you can't concentrate. This is the
so for me in
rat.
these, without any testing, when I just look at their labs and see where do they operate, I'm always like, okay, well, if you're a DI person, you're going to operate towards the high tonicity side because you have your thirst triggering. And if you're a push primary polydipsia, then you're going to operate towards the hypotonic side because you're forcing the system down.
Exactly. But and I agree with you a zillion %, but at the academic institutions, that's not going to be good enough.
Right.
They are going to demand, I tell you this from experience.
Yes, I know.
They are going to demand a formal water deprivation test.
Mm-hmm. We've seen that in the community.
All I can tell you is that the well-known institutions insist on it. Even though I would say that you're going to be right 99.9% of the time, they're still going to want that.
Right.
So that's what gets us to the water deprivation test. And it's not an easy test to do for patients. And it's not easy anymore. In the old days when you could admit a patient to the hospital to do these kind of things, nobody batted an eyelash. But try to bring a not sick person into a hospital in this day and age to say you want to do a water deprivation test. You're going to have a lot of trouble. So but the reason it's useful is it makes the differential between the primary polydipsia versus the DI. And it can also help determine if the DI is a partial DI or a complete DI. And the reason it's crucial, I have to say again, is because while DDAVP, a synthetic long-acting ADH, is the treatment for central DI, a Brattleboro rat, giving DDAVP to a patient with primary polydipsia is dangerous.
Absolutely.
So can you imagine if there's a Brattleboro rat out there who, in addition to the water drinking from having central DI, was also a psychogenic polydipsic? The other rats would say, hey, you got to stop drinking all that water. No, I can't stop drinking the water. So what would happen, Craig, if we brought in a Brattleboro rat for a water deprivation test?
Yeah, that rat, you better follow that rat closely or it's going to end up in a coffin.
Right. So what are the things you would monitor?
Well, you want to monitor their urine output because if it's primary polydipsia, the urine output's going to drop as they stop drinking, but with DI, it won't. The urine output
urine
will
output
continue.
is the key, and you've identified a very important thing.
Yeah, that's what
else will happen?
Yeah,
what other thing?
Then their tonicity is going to start going up.
Exactly.
And it will keep going up in someone with DI, but with polydipsia, depends on how much they've washed out their medulla. But they should.
And that's great that you bring that up because, again, as usual, you're right on target. You're going to see that. Yeah, and so clinically, one of the other things we follow very carefully is the patient's weight, because there's a rule. If a patient, during a water deprivation test, you're only allowed to lose so much weight. If you lose more than the amount you're allowed because you've lost water, the test is stopped. Okay?
Yeah.
So this is what it's used for. Now here's the possible results, and I love this slide. So here's the possible results. Let's start with black, because the black is normal, or blue, whatever that is. Mm-hmm. So this is a plot, not of the serum tonicity, like you were saying, Craig. It's the urine. So remember, something completely different may be going on in the serum.
Right.
This is urine. Now here's a normal person. I tell you, Craig, stop drinking, and I follow your urine osm. As you stop drinking, your kidney gets the signal from ADH signaling to extract more and more water from your urine. And look at this beautiful, even after only a couple hours, and once you concentrate to the maximum, 1,200 if you're human, and maybe look like 2,000 if you're a rat, it stays there. And then if you give them synthetic vasopressin, no other effect happens because they're already maxed. They're already at the ceiling.
Right.
So they're clipped out. So do you understand that curve?
Yes.
Okay. So let's go to the second curve, which is, I want to go to the green curve,
okay,
which is the psychogenic polydipsic.
Right.
Now you had said, repeat what you had said about what would happen if you brought this person in for a water deprivation test.
Yeah, that their urine osm would go up, their urine output would drop off.
Yeah.
And because they'd be conserving water, but they wouldn't be able to conserve to a maximal concentration because,
right, why?
Well, because they've diluted out their countercurrent. So they don't have the driving force to pull to get to that level of concentration.
Excellent, correct. So this is exactly right. So you actually said it before, and I was saying, boy, this guy's smart. Because, so
I was trained by the best.
Yeah, the curve looks the same in shape, but it doesn't achieve this because instead of a maximum of 1,200, these people have taken in so much water that they've actually lost that ability. They haven't, and again, not only have they taken in a lot of water, but importantly, Craig, as you pointed out during the countercurrent multiplication talk, they have stopped. This is, again, solute depletion. Psychogenic polydipsics are tea and toasters without the toast.
Right.
Okay. They're not eating. They're just drinking the water. So they don't have the solute to generate the single effect that we talked about. They may be, in this particular graph, it shows them only getting up to 700. But that makes sense, doesn't it? Okay. Now let's skip and go down to the, let's go down to somebody whose V2 receptor doesn't work at all. Now what happens?
Yeah, nothing happens. They have no way to draw water out. Right. So they're trying to secrete ADH, but nothing's happening. So
So if you were measuring their levels, their ADH levels are redlined. They're
maxed out.
Top. But the kidney is ignoring it.
Right.
Okay.
So they're still putting out a very hypotonic urine.
Yeah, and their body's getting hypertonic.
Right.
Okay. Now, what about the Brattleboro rat? Here's the Brattleboro rat.
Right. So the Brattleboro rat can't make any. Yeah, it's this. The Brattleboro rat has no ADH.
Right.
So but when they give them the aqueous vasopressin, they respond normally.
Yeah, they start to look like the primary
normal curve.
So again, look at this. They kind of look like the primary polydipsic because these rats have been drinking so much water.
Right. They did the same thing. Interesting.
So that's why I'm saying
very cool.
It's cool to look at these curves because of course the complete nephrogenic DI doesn't care about the ADH. The central DI Brattleboro rat does definitely care about the ADH, but can't be normal because of the history of such water drinking.
Right.
And they will drink water to the exclusion of eating the food.
Right.
So, because they are so, as I've said before to you, the only thing that biological organisms will pass up sex for, there's only one thing they'll pass up sex for, and that's thirst. So they will pass up food and sex. So the Brattleboro rat is so busy trying to replace its water loss, it doesn't eat enough solute to get back to normal.
Gotcha.
And you predicted that, Craig, and I think it's because you paid attention.
I always paid. I go back and watch them over and over again, Alan.
Well, I think if you remember whether you learned it first as a fellow, even if you did or didn't.
Told you my third take of the boards is going to be the best,
right,
or the worst.
Yeah, well, all the worst, but
I'll be smarter for them. That's for sure.
Right, but since our podcast, you've gotten you really so.
I've always loved this because this is your baby. This is one of your babies.
And this is on the boards.
Right. This is no question. This is
very testable.
Oh yes. This stuff you got to know the basics.
So they will give you unlabeled curves and tell you to identify. They'll give you a case, and these are unlabeled curves, and you have to say which curve goes with this case.
Exactly.
So that's why I lined them out here.
And then the partial central DI, the pregnancy, for example, that makes
Yes.
sense here because you have vasopressinase inhibiting the ADH effect, so it's not on the normal curve. But
Yeah.
then when you overwhelm the vasopressinase by giving more, then you
Exactly.
get the effect. Yeah.
Beautiful. And they
Yeah.
do better than the drinkers.
Right.
Yeah. Okay.
Cool.
Beautiful. Okay. So here's the recapitulation of that. The water deprivation test. A normal person, urine osmol becomes maximal as body tonicity increases. Then, of course, DDAVP has no effect.
Right.
The drinkers, similar to normal, but not as fast or concentrated because of the washout. And then DDAVP has no effect. Partial central DI is like you just said, like the pregnant woman. It increases, but not fully. Complete central DI, almost no response, like the Brattleboro rat, until you give the DDAVP, and complete nephrogenic, nothing.
Right.
So which would you rather, if somebody said, I had to give you complete central DI or complete nephrogenic DI, which one would you take?
Oh, you definitely want the complete central. You just want something missing that you can just add, as opposed to a defective receptor.
Exactly. But if somebody said to you, look, there's something missing from your brain, yeah, I'm going to pick, which would you rather have, something missing from your brain or something missing from your kidney? People would say, oh, take it from my kidney. I don't want anything to take from my brain.
Unless you have a defective aquaporin.
Yeah, right. But here's one of those cases where you say, take it from my brain because I can sniff a little DDAVP.
Right, exactly.
All right. Yep. So that's the deprivation test. So here, let's look at some of these of the people that get these things. So primary polydipsia is rarely due to a defective thirst mechanism. I think when I was I was a medical student and an intern during the AIDS epidemic, and saw a lot of very advanced AIDS with all those brain lesions of the parasites and all the bad things. And I do believe that I saw a man with advanced brain opportunistic infection brain lesions that actually interfered with his thirst center as a intern.
Mm-hmm.
But it's rare. So what can do it? Well, people say lithium can affect thirst in a certain way. Neurosarcoid can, maybe Al Capone was, he died of neurosyphilis. TB can get in there. And of course, lesions in the brain, if they're targeted, a multiple sclerosis lesion could get there. Then, as you and I have talked about, as a fellow at Yale, I remember seeing a guy who hit his head on a windshield and had temporary diabetes and central diabetes insipidus. So he was a water drinker because of that. It was secondary. But apparently trauma can also induce primary polydipsia. I've never seen a case.
But these are causing a defective thirst mechanism. So that's something with the osmoreceptors like this. That's what we're talking about here. Like
the thirst receptor, right? The thirst place and the osmoreceptors are in slightly different places.
Right.
So they can be targeted differently. Okay. So this is also dipsogenic diabetes insipidus. It's the push polyuria that I talked about. Mm-hmm. And then there's the category of the psychogenic polydipsia, which is still primary polydipsia, but it's associated and said clinically with a severe emotional or cognitive dysfunction. See, the difference between these two is that the thirst center of the psychogenic patient is normal.
Right.
The thirst center here may not be normal.
Right.
So that's the difference. Mm-hmm. It's subtle, but that's the difference. So if you're ready for a case, Craig, let's try a case.
All right, let's do it. Let's see what you got.
Okay. So this is a case from Burlington. This was a 35-year-old man who was down on Church Street. We've had some fun on Church Street. You've even played music on Church Street.
I have.
Yeah, Sweetwater's,
a couple places there.
Yeah,
I love the music scene in Burlington.
Did you ever do Red Square?
I played Red Square before. Yep.
I know Red Square says there's a plaque up there that says Craig
has been here, has played here.
Craig Hurwitz played here.
I came in second place 3 years in a row in the guitar, expo there in Burlington.
I was sorry to have.
Aaron Flynn always beat me.
Oh, I was going to say I was sorry that I always beat you. Why did he always beat you?
I don't know. He's great. He's great, and I was just okay. So it was good. But I came in second, so that's not bad.
Hey man, I thought you were great.
Hey, those were good days.
In my contest, you're the gold medal winner.
All right, perfect.
So anyway, this guy is down on Church Street.
All right.
35-year-old man, noticed to be drinking a large amount of something and is found down in a big pool of urine. So he's admitted to the MICU.
First clue. It's always in the history, Alan.
Yeah, I was lucky to be on service when this person came in. And I remember him coming in, not responsive and with a Foley catheter. And that Foley catheter was like a fire hose.
Mm.
So he was clinically euvolemic, but sodium concentration was 112.
Clue.
And he was making 1.5 to 2 liters of urine
an hour.
And it was the lowest urine. For somebody to get their urine osm below their age, Craig, very rare.
Yeah, that's impressive.
I have never seen a urine osm in an adult that low. So unfortunately, before we got called, the MICU team started the patient on hypertonic because they saw him not really very responsive and at 112.
Well, look at that free water he was putting out.
Right. So they started him on 3%.
They should have just stopped the garden hose that was going in the mouth.
Well, they did. He's intubated
right. Now he is, right.
But you see, here's the reason why starting 3% is not a good idea in this case. This guy's problem was he was his water defect.
Exactly.
And he's now got his kidneys are now, this is like you come home from a vacation and you see your whole basement is flooded with water. You basically start getting rid of that water as fast as you can. As soon as the guy stops drinking, the kidney's getting rid of water as fast as it can. He's got a rip-roaring aquaresis going on. He's going to overcorrect, Craig.
Big time.
In fact, when I saw the guy, I said, not only should you not give him hypertonic, you're going to have to give him DDAVP.
Right.
It's the absolute opposite.
Yeah.
So differential diagnosis is psychogenic polydipsia and polydipsic polyuria. So should hypertonic saline have been given? No. He didn't have SIADH. Right. He was already making maximal dilute urine.
Exactly.
And this additional solute in the 3% actually made it worse because he had to now excrete that solute, which obligated more water loss. Look what happened to his sodium concentration in 4 hours, Craig.
Ooh. The brain doesn't like that.
What in your case of your guy with the 104? What was your target rise in sodium concentration?
Yeah, I mean, in the first 4 to 6 hours, maybe I'd get him up to like 116, go up by 4, and aim for maybe 6, maybe 8 in the first 24 hours.
Right. So I like 4. I like your idea of 4 when it's really low in the first goings.
Yeah.
And then 6 a day.
Yeah. That's very safe.
But how much more times is 20 in 4 hours?
Oh.
What's that in a day?
Forget it. I mean, this is
so 20 in 4 hours.
Right.
Well, that's 20 times. There's 6 4-hour periods in a day.
There's good news and bad news here.
Yeah.
We have water and you can stop this.
Yes. So even in the days, even if they weren't comfortable with giving DD, the easiest way to stop it is to give them some DDAVP.
Right.
So if we saw this case today.
Well, the first thing is what is his DDAVP doing? His is off. He has no DDAVP coming.
Yeah, he's completely
suppressed.
Right. So if we saw this case today, the first rule is don't panic.
Right.
The second rule is assess how the situation has changed. He has stopped drinking.
Right.
I mean, the seizure saved his life.
Now, this would be a totally different case if the urine osm was 600, and you would think differently. So the beautiful thing about this case is the urine osm tells you what the problem is. The kidneys want to tell you. It's always in the urine.
It's always, yeah. So the story in the urine tells you. So this guy has already dangerously overcorrected. And this is dangerous.
Right.
Going 20 in 4 hours.
Yeah.
So the way I would treat him now is he's making all this urine coming out of all this water coming out of his Foley. I would slow him down with DDAVP so that he would go from 112 to 116 in the first little bit, maybe the first day. And then as the DDAVP wears off, I start to see where his aquaresis is, and I either give him more DDAVP or water. Right. Now, the easier thing to do is DDAVP, because controlling the channels is easier than controlling the driving force. So you understand that giving water for water loss is trying to control the driving force. It's like keeping that level of water in a cup above a certain level when the cup's got a hole,
as opposed to changing the permeability.
Yeah, I mean, when you have a slow leak in your tire, you've got two choices. You can continue to put air in as air is lost, or you can patch the hole.
Right.
Now, which one is recommended?
Right. Well, in this case, you're patching a hole for something you still want to leak.
You want to leak, but the DDAVP, if you control the dose and give a low enough dose.
Yes, that's the point. So you want to do a partial patch.
You want to do a partial
in this
patch.
Guy's case, actually, right now you don't. You want to shut it off. You want to make him a beaker so you can fix the problem of his brain exploding.
Well, that's the whole point. You want to first beakerize him,
right,
so that you have a starting point, and then slowly let up on it.
Right.
So what should have been done? Allow the patient to excrete excess free water. If the sodium rises too fast, can give DDAVP or free water. We talk about it. So but if this was a board's question, the wrongest
answer is definitely 3%.
Answer.
Exactly.
This is the wrongest answer.
Wow. That was a mistake.
That was a mistake.
Although if you read up to date in hyponatremia, it's like severe hyponatremia. There's that algorithm.
Again, that's the one can argue there's no doubt it's the most read topic. The question is it the most read topic because people want to understand it, or is it the most read topic because no one understands it?
Right.
And after they read it, they keep reading it.
They need to go to the podcast, Alan. We need to go to the video cast. Yes. Salt and water, man. That's a great one.
Right. And so I gave a little mini lecture to the
fellows,
to the MICU staff.
Oh, nice. What'd you talk about?
No, when this happened.
Oh, when this case happened.
When this happened,
oh, okay.
I said everybody in the conference room.
A roundup.
Time for a sit down.
That's a good one.
Okay. Now this one was due to a water diuresis. It's clear, right?
Yeah.
So let's look at a case where it's again going on in the hospital, but this is a solute diuresis. This is another case I saw. This guy was on Baird 4. You remember Baird 4?
Of course.
Okay. So, I mean, it's great to talk to somebody and I can say, hey.
Yes, I remember. I know exactly what you're talking. I know the rooms.
We lived our life on Baird 4.
Wow, that was great.
Yeah. And one of the funny things, there was a guy in Baird 424 when I first came as an attending who was a psychogenic water drinker. And nephrology had done the best they could to limit this guy's water, but he was in a wheelchair and he tooled around. And he learned how to unlock the kitchen.
Oh, that's classic.
So he was still drinking, and nobody knew how he was doing it because his bathroom was closed off from the toilet. But the guy was smart enough to watch the nurses enter the code on the kitchen door.
Wow.
And he was drinking all the ginger ale. Okay,
They find it where there's a will, there's a way.
Absolutely.
All right.
So this is a different guy on Baird 4.
All right.
70-year-old man who was admitted for pneumonia. And he develops delirium during treatment. Mm-hmm. So he needed a feeding tube. And for some reason, they placed him on tube feeds and a very high protein supplement. This is going to tie into several things we talked about, Craig. Mm-hmm. So the patient weighs 120 kilograms, is a big guy, and was receiving 4 bottles of these tube feeds.
Wow.
His urine output increases to over 4 liters a day for 3 straight days, and they call me. So I find the guy awake, but not really very responsive, clinically euvolemic, good sodium concentration, and a urinosm of 660. Don't forget, he's 70. He may not be able to do the 1200 of the good old days. Mm-hmm. But what's the differential diagnosis of 4 liter? Now, we all agree that's polyuric.
Right.
So this is a guy who can't be drinking water.
What's his BUN? It'd be nice to see the rest of his labs, especially with that high protein intake, what's going on there. And
yeah, that would be nice. I don't know that I remember the BUN, but something tells me it wasn't normal.
Yeah. But anyway, what you see with these two labs is just a guy who has a large urinary volume, but he doesn't have dilute urine.
No, so this is not a Brattleboro rat.
Right. And he's got
And
normal tonicity, at least from the standpoint of sodium. We don't know about glucose or BUN, the other two big.
It was normal.
Okay.
But he's not a water drinker.
Right.
So what's the difference in diagnosis of polyuria? Well, the obligate solute load of the patient, of most of us, is 10 milliosms per kilogram per day. And at 120 kilograms, that's 1,200.
Mm-hmm.
So if he could do 1,200 in his loop of Henle, that would obligate him to 1 liter a day.
Right.
But he can't do that. But he'd have to, if he could only do 300, it would obligate him to 4 liters. But he's doing better than 300.
Right. He's doing 600.
But I looked at what was in the tube feed, and I found that he had 500 milliosms per liter in his tube feeds.
Okay.
And he's getting 4 of those.
Right.
So this guy's got a total solute load of 3,200 milliosms per day.
So he's doing perfectly.
Yes.
For what they screwed him up with this excess tube feeds, this guy's amazing. He kept his sodium at 139, and he did it by making his urinosm 660 and putting out 4 liters of urine a day. Good man.
So when
doctors.
So when the medical team who consulted me said, "Did you find the cause of his polyuria?"
You said you.
I said, "Yes, it's you."
Oh, that's so funny.
And so I said, "This guy should be making 4.85 liters a day. You should be happy it's only 4."
Right.
Okay. So,
funny.
this is physiology. What you're saying.
Yeah, I love that.
Physiology in action.
Yeah, you got to love it.
So, of course he's going to have to do this. I mean.
Well, this is a really beautiful one because most of the time you can't measure the milliosms going in. We estimate. And in this case, you had milliosms per bottle. You knew 4 liters. You knew it was going to be 2,000. This was a perfect one because using the urinosm and what went in, you knew exactly how much urine this guy had to make.
And even though this case was years and years ago,
so funny.
I thought to myself, someday Craig and I are going to have a podcast.
We're going to laugh about this one. It's great. That's a great case.
So let me ask you, if you were having this solute load, how much urine would you have to make?
I'd probably make like 2.53 liters because I think my concentrating ability is pretty good.
Right. But even that gets you into the polyuric range.
Right. Yeah.
So you have to, so when somebody's polyuric, you have to ask yourself, is it a water diuresis like this guy? Mm-hmm. Is it a solute diuresis like this guy? Mm-hmm. Or is it a combination of a solute and water diuresis? And that's why if you read the ASN forum every day, I do, mm-hmm. There'll often be a case of polyuria, and somebody writes back, this is a water diuresis, and somebody writes back, this is a solute diuresis, right. And then somebody writes back, this is a solute and water diuresis.
It's a combination. There needs one more nephrologist there for the tiebreaker.
Oh, you know who always breaks the tie?
Who?
Aaron, the guy who beat you in the guitar thing.
Oh, Aaron Flynn. That's
Flynn's
awesome. He always gets it. He comes in first place in everything he does, even in nephrology. I can't beat this guy.
You can't beat this guy. He's unbeatable.
He is.
Okay, so those are some illustrative cases. So again, now let's talk about the regulation of body tonicity. Of course, the steady state we're talking about is the water excretion rate must equal the water intake rate for you to stay isotonic if you start isotonic.
Okay.
So you lose water sensibly. That just means you can feel it by the gut and the kidney. And then there's insensible losses of the airway and the skin. I mean, you're sweating, but you don't really, I don't know. This is how they call it. I would just say sweat, humidity from the airway, urine, and stuff from the gut. I don't know why we have to give it these crazy names.
Mm-hmm. Yeah.
I don't find that helpful. Mm-hmm. And I think, in an age where there's already enough complexity, I don't think we need to add to it. I would just say, where's the water being lost from? Did you get a burn and you're losing it from the skin? Are you sweating? Is it coming from hyperventilation or not having humidified air? Is it the urine? Is it the gut? Mm-hmm. Anyway, and then there's a gain of water. Now, gain of water is motivated by thirst, as we talked about, but you also have to have access to water and you have to be able to drink it. Mm-hmm. So there are plenty of people in nursing homes who feel thirsty. A water is sitting right at their bedside table, but they've had a stroke and they
Right.
can't get it or
Exactly.
tell anybody.
Right.
So gain of water is motivated by the brain, mediated by the gut, and you need muscles to act on it. You need an arm that can pick up a glass of water.
Right.
And then there's the convenience factor. These are the things you need. This is the convenience factor. ADH is very convenient to have.
Right. You can survive without it. Right.
You can survive without it, but it's convenient.
Right.
Like, would you like ADH with that? Would you like fries with that? Yeah. I'll take isotonicity. Yes. Would you like fries with that? You mean the ADH? Yeah.
Take it.
Okay. So you need two things. You need to be able to release it from the brain properly. Not too, again, Goldilocks, not too little, not too much, just right. And the kidney needs to do the right thing with it.
Right.
Okay.
Perfect.
So here's the classic first, again, this is maybe the first slide I ever saw that showed the real experimental data points of that ID. Remember the idealized slide I showed you from the textbook of ADH?
Yes.
Well, here's where that idealized figure comes from.
Okay.
This was, I think, a Gary Robertson
right. That
paper
ADH comes on late, that the thirst triggers later into the ADH secretion.
Yeah. So this was the classic vasopressin osmolality curve with the dots. And then here's what happens to your.
They didn't fit that. They tried to fit that linearly. Look, can you see there's a linear curve on that? That is not a linear.
Yeah, they tried. I mean, we would never do that.
No way. No.
Apparently in the late
Neither
70s,
one of those is fit appropriately. They need origin. This was back when they actually pasted dots onto something, and it's like the angry Nephron. I don't know. I'm not happy with this.
I think in the 70s there were computer programs that could do.
They should have done better curve fits.
They could do fits.
Yeah.
All right. Well, anyway, now I want
because
you to explain.
you see that asymptote coming as AVP. As AVP goes up in terms of when you hit your maximal urine osmo on the graph on the right. They don't show you reaching that, and they should. This is a perfect one where it should. Maybe we should replot. We need to refit this data, and
all right.
That'd be cool.
That would.
What
be cool.
does this old data really show? Because they probably can't even describe it in the text. This was in '77. They could fit curves back then.
Yeah, they could, and we could do it.
Yeah,
maybe somebody already did.
I bet.
But let's see. But the next slide's for you to explain, Craig. Tell me what's going on here. This next slide.
Okay.
Right. Whoops. Wait a minute.
I had thought, because I love the Aldo paradox, and I'm like, doesn't ADH have a paradox? Doesn't it have two triggers where something can be wrong with tonicity, but then again something can be wrong with volume, but not really in this case? You've explained it to me, but basically,
well, there is a such thing as ADH escape, there's Aldo escape that people talk about. I don't really believe in that either, but there is an Aldo paradox, but that's because it's controlling two different systems: sodium reabsorption through ENaC and potassium secretion.
I want to do another short podcast with you to talk about the Aldo paradox in more detail, which I read more about and is so cool.
Yeah, we'll do that.
Okay.
But what's going on? What's going on in this graph?
So here, the relationship between.
If I could just
start at the normal. Start at the black.
So
the black is normal, and you can see as the osmolality goes up in the plasma, you release more ADH. And they show basically a linear relationship there. But now they're showing you what happens in the setting of volume changes, what happens to your ADH regulation.
Right.
And as you shift towards hypovolemia, it takes less tonicity change to trigger a bigger ADH response. Steeper, right. So it's steeper. It goes up faster at a lower tonicity. It's more sensitive to tonicity change. As opposed to when you get hypervolemic, your tonicity changes become less responsive to the same amount of change in your plasma osm. So yeah, you become less responsive.
So with the ADH, if you talk to the ADH system, what it wants to be, its dream is, let me live here.
Right.
Let me live here because I want to take care of tonicity more than anything else. This is like Dina saying, listen, Craig, let me have the babies.
Right.
You're going to not do a good job.
When they say -10, what do they mean by?
This is percent.
Okay, percent
so a minus
of volume.
10%, a minus 10% loss of volume.
Okay.
This is basically from what would be considered mild volume depletion to severe volume depletion.
I see it, arterial.
And this is mild volume overload to severe.
Okay.
So these are percents.
Okay.
So they're saying that the ADH system would like to live here and just deal with tonicity.
Right.
But if volume forces it, the ADH system says, if you force me with low volume, not only will I be secreted earlier, I'll be secreted more sensitively, because we're desperate to pull out all the stops.
I will sacrifice tonicity for volume.
Always will. But it would rather just be in the tonicity game. This is like finding somebody, this is like in baseball.
Right.
You have a pitcher that says, look, I'm not going to hit. Get a designated hitter. Let me just pitch. But then one day, the pitcher has to bat.
Right.
He doesn't want to. Just let me pitch. That kind of thing.
But he has a uniform and get him.
So that's exactly right. So what happens, the shape of the ADH curve, this is the classic when euvolemia obtains, but this is subject to clinical volume status.
Right. Okay. Understood.
And I think this is very good.
That's actually a nice graph. I've never seen this one before. Yeah, well, and that's really nice. What's that from?
I think it's a very important graph, but the other thing about it is that this is sometimes emphasized so much that it helps people get confused between salt and water. Because as much as I would like to say ADH is just your water hormone, your tonicity hormone, this graph prevents me from saying that.
Right.
And it's that crossover that is great physiology, but leads to sometimes confusion.
Mm-hmm.
Okay, so what's next? Now let's look at the woman who was a Brattleboro rat. I've told you about this lady before, Craig, the 40-year-old woman from Bulgaria who came to clinic because she was working at a new job, but she couldn't hold her job because she couldn't hold her urine. She's always going to the bathroom. She has a water bottle with her. She needs to urinate twice while I'm seeing her. Clinically, she's euvolemic. Now, you said, Craig, you could look at the serum sodium concentration of 142 and tell me whether she was a drinker or a DIer.
Well, especially with a urinosm of 40 milliosms per kilo. And how much urine was she putting out?
Oh, I don't know. I mean,
large volumes of if she's over 3 liters, which I'm sure she is, she's probably 4 to 6 liters a day.
Yeah, she is.
She's got to be, if she's taking in a normal 800 or 1,000 milliosms a day, she could be making a lot more than that. It's amazing.
Yeah. But you had said that you could sometimes look at the
she's operating at a higher tonicity. She at the upper. That's even pretty good. 142. I'd think But if she's drinking appropriately, that's impressive. And her osmolality is 292, upper normal. This makes me think this is not a psychogenic polydipsic. This is someone who's got a pull polyuria.
Right. And here's the water deprivation. I did a mini water deprivation test on her.
Mm-hmm.
Very quickly on her serum sodium
went to 147.
147. And look at the change in her osm was not very big.
But she made no real change.
Her
urinosm didn't change.
Yeah. And then I gave her desmopressin, and everything was good. So she's a Brattleboro rat.
Yeah.
And all she needed, just like the Brattleboro rats, all they need is to sniff some DDAVP.
A couple times a day.
Yep.
And they just regulate their urine output.
Right. So this is the human counterpart, and she's the one who had a sister who has the same thing. So it turns out that these two sisters have congenital central diabetes insipidus.
That's awesome.
Now, go ahead and explain this one, Craig. This is the differential diagnosis of the several different types of diabetes insipidus, where you see the osmolality on the x-axis and the vasopressin level.
Yeah.
So let's just go. Let me ask you a question, then you tell me what dots have to be.
I see the triangles there. They're central DI severe. Those people have a higher osmolality. Actually, these are so nicely separated out that machine learning could identify what disease you have perfectly in this case, because there's very little overlap.
Yeah. So you're saying that these kind of data really are ideal for those kind of techniques.
They are perfect because there's really very little overlap between these disease states, and a computer is very good at identifying those shaded areas where these things cluster.
So maybe this should be one of our first things that we model.
This looks like it might be one of the easiest ones.
Okay.
I'm going to show this to Jack and see if he can help us do that.
Okay. And we don't have to belabor this because I think people can just look at this and just see, based on what we've talked about already, that this makes sense. And the thing I was hoping you would point out was exactly what you did point out, that you would say, look, man, I see these dots and these data as being very amenable to methods of machine learning.
Right. And if you see all the central DIs, whether it's severe or partial, they push themselves out of the normal tonicity range. So they're high tonicity and they have no plasma vasopressin. So they're right where you would think they would cluster up.
Exactly.
And then and that also helps you understand where thirst would come in. That almost identifies that thirst point that they show where on the normal curve, your ADH would be already secreted.
Exactly.
And these people are operating around and above with the lowest level, their threshold being the thirst drive, not the ADH secretion drive. So these people are operating with a low normal of 290 where low normal is 280. They're 10 above for their low point.
Right.
So it's pretty interesting when you look at where these numbers cluster. And that's both the central partial and central severe. And then if you look at nephrogenic DI, just as you would expect, they have a massive amount of vasopressin. So they're shot way up at the top of the curve there. And these people are drinking and they're drinking and they're operating in the normal range as far as their tonicity goes.
Right.
And then dipsogenic DI.
These are the psychogenic.
Yeah, so the psychogenic people, they're fairly normal range, but their vasopressin is suppressed.
Right.
In general. But this
is what happens. I think this is how they respond to the water deprivation test.
Okay, so this is right. Yeah.
So that's why they have ADH. They don't have an ADH problem.
Right.
Okay. So then just to review what we talked about, what's going on to the nephron, and I'm not going to spend a lot of time on this, but we talked about how along the proximal tubule is isotonic reabsorption of isotonic saline. So there's no change in osm, just a loss of 70% of the filtrate volume. Then the loop of Henle concentrates and dilutes, setting things up for the collecting duct to either act like a switch, either no ADH or secrete ADH. So the urine output for a person who has a GFR of 180 liters a day, the urine output can be anywhere from 540 mils if you're maximizing your ADH to this huge amount if you don't have any ADH whatsoever.
Right, you have a huge capacity to excrete or conserve water.
Exactly, and that's shown here on this slide. The same kind of thing. I'm not going to spend time on this. We talked about this a lot. Yeah. It just shows the difference between, we talk about requirements for water excretion. Solute and water have to make it beyond the proximal tubule. Then the tubules have to work, and you have to be able to do the right thing with ADH. So that's just the physiology. And then here's just showing, as you saw with my Bulgarian lady, who for 40 years, this lady apparently had aquaporin 2 water channels right below the apical membrane. She just never could push them up. Because here's what's supposed to happen. What's supposed to happen is before AVP, they're sitting in the vesicles.
Right.
Then as you give AVP, they all fuse. And now you see they're all in the membrane now. This is the apical membrane. They're all in the membrane. And then they get endocytotically reuptake happens, and they're pulled off the membrane. But just the miracle that my lady could live 40 years with these little vesicles just sitting there waiting, like put me in, coach.
The system remained intact, right? It didn't.
Remember, it's like the guy that sits on the bench forever, and then the coach says, "Get in there," and he hits a home run.
It's amazing.
Okay, so this is again recapitulating maximal ADH. I just show that for review. That's when
and I'm going to put links underneath here to our little segments that really detail water movement along the nephron, which would be helpful.
And the countercurrent.
And the countercurrent. Right.
Yeah. And then here's the absence of ADH. And again, absence of ADH because it's either really absent or effectively absent. Mm-hmm. I mean, there's not much difference from the kidney point of view, from the urine point of view, not having ADH and ignoring ADH,
Two different things.
Right. I mean, it's like, when I was in college, I was exposed to women, but they ignored me. So I had the equivalent of nephrogenic no dating. I wasn't in the desert of no women.
I don't know.
I was in an unresponsive state. Speaking of nephrogenic, let's talk a little bit and finish up here with nephrogenic DI.
Okay.
So nephrogenic DI, you can acquire it or you can be born with it. So the congenital forms, and this is particularly covered very well by the Dutch groups. Apparently in Holland, there are a number of families with X-linked recessive V2 receptor defects. So, in terms of congenital nephrogenic DI, that means either there's an insufficient or absent effect of ADH on the V2 receptor.
Right.
The majority of the cases are because the V2 receptor is got this X-linked recessive thing, and it's a receptor.
Mm-hmm.
And 10%, the problem is a defect in the actual water channel itself.
Right.
Okay. Now, there are acquired nephrogenic DIs. The most important for us clinically are lithium therapy and hypercalcemia.
Mm-hmm.
We all know, and we explained in our countercurrent. Remember, we talked about type 5 Barters. Remember, Craig? You love that. So we talked about how calcium could do it. We talked about how hypokalemia could do it, because you need to be able to recycle that K across ROM K. If you don't have enough K to recycle the K across ROM K, you're going to have a defect. Malnutrition, amyloidosis, blah, blah, blah. Some chemotherapies are important. And then there's the solute diuresis of glucose, mannitol, other stuff, including contrast dye. And we talked about post-obstructive.
Mm-hmm.
But just to go into some of this a little bit, here is the congenital nephrogenic DI. It's a small table. This is just shows a table of, patients who have a mutation in
either the receptor or the aquaporin
receptor 2. Or their water channel. Again, these are rare enough that reading this table and memorizing isn't going to help you.
No.
It just to know that it happens congenitally, genetic, and that of the genetic ones, most of them are the receptor on the basolateral membrane, but sometimes it's the actual aquaporin. Okay, here's a little snippet of the X-linked recessive, and here shows the different mutations. This is 90% of congenital. It's X-linked recessive, so it's going to be males, because the women are heterozygotes. Most mutations are lead to defective trafficking. And it turns out that as infants, it's very important to pick this up early.
So defective trafficking of the receptor into the basolateral membrane.
Yes.
Okay. Cool.
Yes. And then you have to catch these kids early, because if they have repeated episodes of water loss, hypertonicity, dehydration,
that's bad.
They really have bad mental and physical development. Okay. Here is the other thing where the defect is in the trafficking of the aquaporin 2 channel.
Right.
This is very rare. And again, here is the aquaporin 2 channel with, again, its some of the identified mutations. So it's, again, anything that can go wrong will go wrong, and it could be any part of the system. Now, clinically, for what we see, the acquired is going to be the thing that's more important clinically.
Yeah.
So the two big metabolic ones are hypercalcemia and hypokalemia.
Mm-hmm.
Chronic kidney disease, because obviously, this is the organ that's doing it.
Mm-hmm. Polycystic,
post-obstructive.
Mm-hmm.
We talked about systemic diseases that affect the medulla or infiltrate the kidney. But here's the big category. Lithium is frequently does this.
Mm-hmm.
I've read somewhere that 54% of people who are on chronic lithium therapy could be demonstrated to have some amount of nephrogenic DI.
It makes sense.
It does. And then we'll talk about the mechanism in a second. But lithium, don't forget, lithium is the only thing better than sodium going through ENaC.
Right. It's in front, goes in front of the line.
Yeah, so that's why I was joked with you about lithiumide, the combination lithium amiloride. Take your lithium for your bipolar disease, but have some amiloride to block the channel.
Exactly.
Lithiumide. So dimeclocycline, infrequently used nowadays, but when it was used, it was a common cause. Here's you always got to think of this with chemotherapies. Mm-hmm. I don't know how often you use foscarnet. Orlistat is a drug that was available at Costco over the counter for weight reduction.
Wow.
Amphotericin B, of course, pokes holes in membranes. Aminoglycosides can really do it, and anesthesia. And then just getting older. As you get older, you can't concentrate as much. You don't have a mutant receptor or aquaporin, but you just don't have the kidney you had.
Somehow Clotho's involved with that.
Somehow Clotho. So here's the water deprivation. Here's what happens if you do water deprivation tests on a nephrogenic DI person versus a central DI. So let's first look at urine osm, because that's the classic. So we already said, here's the normal person. The nephrogenic DI doesn't respond to the DDAVP. The central DI patient concentrates the urine after the DDAVP, of course. Mm-hmm. And then here's what happens to plasma. Normal, you can just sit there for 20 hours and nothing happens to you. Right. And central and nephrogenic are on top of each other.
Until
difference, of course, is when you give the desmopressin, and again, 2 micrograms. So when you want to clamp somebody with AVP, Craig, you can give 1 to 2 micrograms of desmopressin.
Right.
And of course, this immediately is the cure for the central DI, because it's what's missing, and the Nephron ignores it. Mm-hmm. Okay, so it's a very consistent thing. Here's a little slide on lithium, the mechanism. Good. Lithium is interesting. Lithium does a lot of things. It affects thirst. Lithium affects every player in the system. It affects thirst. It affects AVP secretion. So it stimulates secretion of AVP. You would think it would cause SIADH, but it causes nephrogenic DI because it accumulates in the principal cells via ENaC. It impairs, it actually increases, it stimulates AVP, but maybe it stimulates it because it decreases the effect of AVP on the ability to produce cyclic AMP. So you need more. I don't know that lithium is stimulating the AVP. I think maybe the fact it's not working well is stimulating more AVP. You see what I'm saying?
Yes.
And then it also reduces the expression of aquaporin. It reduces the expression of urea transporters. Mm-hmm. And all of these are going to basically favor a DI situation. And it's often irreversible. So I have patients who were on lithium for 20 years. Right. They're now off of it, but they still have their DI. So this is a brick that goes through the window. You can hide the brick, but the window's still broken.
There's something about the aquaporins forming like tetramers or something. It changes how they form together so that they can't be released into the membrane either. Like
right. So there's again, it's on multiple levels. Trafficking is a big one, and maybe making the channel. Mm-hmm. Now here's something that's on the boards not infrequently. Lithium can produce several endocrinopathies. Lithium can produce hypothyroidism, but lithium can produce hyperparathyroidism. We talked about this in the PTH talk. We showed the curves, but lithium basically can shift the PTH calcium curve.
Right.
So you get hypercalcemic.
Right.
You basically get a hyperparathyroidism. So about 55% of patients receiving long-term lithium develop NDI. 20 to 30% develop polyuria. Therapy for these folks, the low solute diet can help. Thiazides can help. Prostaglandin inhibitors like NSAIDs can help if they don't have kidney disease, but I don't know if you want to use that if they do. Exogenous ADH may help if they have a partial nephrogenic DI. I, of course, like amiloride.
It makes the most sense if the system is still working.
The year I graduated med school, there was a New England Journal paper by my neighbor in Chicago, Dan Battier is at Northwestern for all these years. And he basically did this. He tried to study the effect of amiloride in 9 patients with lithium-induced NDI. And after 24 days of amiloride, he was able to show that the urine volume decreased fairly significantly and the urine osm went up. So just imagine if these people were on amiloride from the beginning of their lithium.
Right.
So I think this is a small study, but it got into New England Journal.
That's interesting.
Yeah. So here's our picture again. And, lithium, you can have a genetic defect of this. You can have genetic defects of the channels.
Right.
But most of the defects relate to either this receptor getting into the membrane right or this protein trafficking correctly, aquaporins. I want to finish, Craig, today with, this is one of our sessions that doesn't go overnight.
Yeah, that's good.
I want to finish with the case I saw shortly after you were a fellow.
Okay.
This was a case I saw with Jonathan Jaffrey.
I love it.
Who's now in Wisconsin. And I think Jonathan is the grand poobah.
He is bigwig.
He's the commissioner of health for the state of Wisconsin.
Amazing.
Yeah. Well, he didn't go into this. He didn't go into the water business. He went into the health businesses administration. It's great. Anyway, this was a case I won't forget because we got called at midnight on a Saturday night. I think if you look back, whatever year in the early 2000s, February 7th or February 9th was Saturday, whatever Saturday in the early 2000s was a February 9th. Mm-hmm. Called it at midnight on that Saturday night. And here was the case. The patient is a 54-year-old man who was admitted for a Whipple procedure. He had a history of colon cancer. He had a history of bipolar disease, and it was on lithium for 20 years. However, he had stopped his lithium because this was 2002. So the admitting history,
years, right?
The admitting history didn't reflect lithium as a current med.
Right.
So because of that, nobody suspected anything. Now look, his baseline creatinine's 2.2. Why? Lithium.
Right.
Just a side question for you, Craig. How many patients on dialysis do you have from lithium?
For quite a while, it's been like 2, but I have one now who's kind of percolating, but it's so slow.
Is it 100% lithium?
Well, it's hard to know. I mean, that was really the only thing, but they also, this one, the 2 I've had in the past, like one was pretty significantly hypertensive as well. So it's hard, probably not just that, but I think of them as lithium-induced renal failure. While you're, in terms of it really leading to end-stage renal disease.
There's controversy. There's one maxim that says lithium definitely causes CKD, but it's apparently very difficult to find patients on dialysis where the only kidney insult.
I have a lady right now I'm taking care of who I have set up she's getting ready for a transplant potentially. And her creatinine is in the high 3 range now, and she has zero else going on. Non-smoker, perfectly fit, just long-standing history of bipolar and chronic lithium.
Yeah. So again, I wish I would be there at the beginning and give them, if not lithiumide,
amiloride, right?
Give them amiloride from the get-go.
Yeah.
Now, the other thing that would be interesting about that is, however lithium helps a person with bipolar disease because of the brain effects,
right?
You would like to know that the amiloride doesn't block that.
Exactly, because we don't really know how that works.
That's right. We don't know how that works. But I think it would be easy if we found out that amiloride didn't cross the blood-brain barrier. Because lithium isn't lithium like number 3 on the periodic table? Pretty small.
Yeah.
Yeah. So lithium's pretty small. So if amiloride doesn't get through the blood-brain barrier, I think we'd be pretty safe. Anyway, here's the guy. When I talked to him, by the way, this guy loved milk. Mm-hmm. He drank
tons of it.
A couple of cartons of milk a day and a total amount of well over 4 liters of fluid. Mm-hmm. But this was a review of systems taken after I saw him.
Okay.
It wasn't the initial chart. And lithium wasn't on the initial chart.
Gotcha.
The blood pressure was okay. Here's his labs when he came in. just his kidney. Now, you also notice that he's got this. Why does he have this, Craig?
He's got a little type 4 RTA.
Yes, he's got type 4 RTA from having tubular interstitial disease from lithium.
Right.
Beautiful. So on the 7th, he goes in for a 10-hour. I mean, a 10-hour procedure, Craig. That's almost as long as our podcast.
It's almost.
Almost. I mean, this guy goes in for a partial podcast. No, he goes in for this long procedure, complicated by a little hypotension. Now, look at that, Craig.
They gave him
received 15 liters of LR.
And 4 packed red cells.
His post-op sodium couldn't be better. Now, 54 hours later, the patient has been having massive polyuria. We get called in when his sodium was 164 on midnight. So this happens, and this is what prompts a call to us. His plasma is 352. The guy's intubated, Craig. And the urine, look at this. Plasma is 352. Look at the urine.
Yeah, 172.
So what's your diagnosis, Craig?
Well, he's got a lithium-induced nephrogenic DI, but now he's got both water diuresis and solute diuresis. All
right, Craig. Perfect. So here are what used to be nice origin plots, but I put them all in one figure.
Let's see.
Here he goes here's his urine output. And you don't need to see the numbers. You just need to see what happened. Here's his urine output.
Okay.
Before the OR and just after the OR, not much. After the OR, look at this. Here's where we consulted.
Right.
Okay. Look what's happened to his serum sodium concentration before, right? And then the OR. Boom. Right. And then we consulted.
Right.
And here's his serum creatinine.
Right. AKI.
So he also had, in addition to this, he had
a water excretion defect from renal failure.
Yeah, he also had AKI, from his hypotension. So he's got ATN, yet the kidney is still good enough
to get to
waste all the water.
Wow, the one thing that's not shown on here is the 15 liters that went in at that time.
Here's our analysis. Here's my analysis.
Okay.
Jonathan's analysis.
Yes.
Jonathan.
Okay.
So here's how I figure it.
Okay.
The guy's minimum, so see if you can follow me here. Bear with me.
Go.
The guy's got a minimum urine output. The minimum urine output is your obligate solute load. Okay. So if you have 10 milliosmoles per day, unlike the tube feeding guy, then if your maximum uosm is 1200, then your minimum urine output is 667 mils. But if your max urine osm is only 200, it obligates you to 4 liters, and that's just on the obligate solute load.
Right.
If he's euvolemic and gets 1 liter of NS, normal saline, he'll need to make 1.54 liters of urine just to get rid of a liter of NS.
Right.
So 1 liter in of fluid results in 1.54 liters out. So this is a recipe for dehydration.
Yes.
To get rid of the 15 liters of LR he had to make 23.1 liters of urine.
Right.
So they gave him this huge solute diuresis.
Right. And he can't concentrate to get rid of the solute plus the water. Right.
Right. And so I calculated that he would have had 8.1 liters of free water loss, which is pretty much what he had. So 80 kilogram man, 48 liters of total body water, starts with the sodium 140, then loses 8.1 liters of water. Here's the total sodium content in millimoles. And then here's what happened to his water. It exactly where he headed. So he hit 168. This calculation showed he had to do that. So if you look back here, he hit 168 right here.
Wow.
And that's what I calculated. So these calculations work. Correct?
Oh, it does. It's amazing.
Okay.
Edelman.
So that's the first analysis, right? The second analysis, he was euvolemic at 80 kilograms when we saw him with the sodium 164. So when I used the water deficit formula that's classically used, and it says that his water deficit was 7.2 liters. So that's the other equation. So he needs to get enough free water to make up this deficit, plus keep up with the losses. So he was losing, it was going to take him 36 hours to correct the deficit, because we told him that he needed a bunch of D5, and then the nurses called us in distress saying, he won't stop making urine. He won't stop making urine. And we said, and what are you doing with the urine? What do you normally do with the urine? They go, we normally flush it down the toilet. I go, why don't you flush it down the toilet to stop worrying about it?
Right.
He's
exactly.
he's going to make a lot of urine.
That's what we need to happen.
Because he has nephrogenic DI.
Right.
So we aggressively, while we were aggressively trying to replete his water deficit, it should not be surprising that his output remained high. Now, this was back in the day, before we were giving people like DD-AVP clamps. In this day and age, Craig, should we have given him some ADH?
That's an interesting one with his nephrogenic DI. I mean,
it might have been a blunted response, but either he would have been blunted or done nothing with it. Right. It wouldn't have hurt.
Right.
Guess what another consulting service suggested? And I'm only going to say, I'm not going to give you the name of the other consulting service people.
They didn't want to give him tolvaptan.
Because it was endocrinology. No.
Okay.
Guess again. What? Guess what they
Diuretic?
wanted to do about the polyuria? No. You'll never guess, Craig.
No, I'm never going to guess.
Yeah. NSAIDs.
Oh.
I remember very, very, I wrote a note, under no circumstances should you give this post-op patient with AKI NSAIDs.
Yeah. And what was their hypothesis on that?
Well, because little baby kids that have, if you want to slow down their urine output for whatever reason, you can constrict their afferent arteriole by giving them NSAIDs. But they're not 70-year-old guys post-op a Whipple with AKI on CKD.
Right.
So this was a pediatrics maneuver. So I wrote, under no circumstance do that. And the endocrinology attending gave me an angry phone call and told me, well, how is he ever going to stop making urine? And I said, I hope he never stops making urine.
Right.
If you're asking, how is he going to stop making a lot
Give
of
him a
urine,
new kidney. That's how he'll stop making urine.
I wouldn't have him stop making urine by giving him kidney failure. That's not exactly what we learned in fellowship. I said, what I would do is, I don't really care about his urine output until his body's good. So let me give him enough water to make his body good without giving him more kidney failure. And I guarantee you, we can get his urine output back to something reasonable when he gets extubated, because this guy lives at home without you and already has 4 liters a day he's used to.
I think an interesting question, if you go back to the first analysis, is that let's say you knew the history. This guy had a 20-year history of lithium. He has you're following him for a nephrogenic DI related to that, where he makes 4 liters a day and he's very well controlled and he's optimized. How do you tell the surgeons how to manage this guy intraoperatively to avoid this situation?
Well, that's a great question. So first of all, I would say to the surgeons, number one, your job is to get him through this surgery, and you do whatever you need to do, whether it's blood or whether it's crystalloid, you do what you need to do. And what I will do is, whatever you tell me you ended up needing to give him, I will tell you how much urine that will cause to be made, so that when he makes that amount of urine, nobody will be surprised.
Right.
You see, when somebody makes a ton of urine, if somebody tells them this is exactly what I expected, they don't panic at all.
Right. Right.
So it was the panic. And so I would say, whatever you have to give. Then we'll do 2 things. We will tell you, 1, how much urine he needed to make to get rid of that.
Mm-hmm.
2, we'll tell you how much water you're going to have to give.
Because he came out of the surgery with a normal sodium concentration.
Right.
Right. And it wasn't
not quite, but almost, yeah.
Yeah. Okay.
But then he was intubated and had to get rid of all that solute, so he already had a water diuresis, and now he had a huge solute diuresis, like you said.
Exactly.
So the different thing is, I would have done nothing differently except told the surgeons after the operation was over, here's what's going to happen to his urine output. We got to keep up with that.
Exactly. That's my point. Like, it's the post-operative water D5 water management that this guy needs to avoid him hitting 168. You know, the problem was they called you at the 168 where they should have called you, you know, well, I'm saying in the best possible scenario where you knew the patient, you could have done that, you know, where you had some kind of tracking of his serum sodium and you're adding D5 to balance his water.
I think if the surgeons, I don't blame the surgeons for this, but I think, you know, when somebody's admitted for a Whipple, the surgeons are worried about the cancer and the pancreas.
Sure.
Okay. And because lithium was not on his current med list,
right?
Nephrogenic DI wasn't on
the radar.
Their radar.
Right.
The only way this would have been picked up is if there would have been a medical student on the surgical surface who would have done one of those complete review of systems.
Yes. This case was missing the med student.
Right. This is a case where the med student might have picked up he's got polydipsia and polyuria.
Right. Good point.
Because he told me he drinks all this milk. His wife came in and brought him just milk. He loved milk. He's from Vermont, loves milk. So, you know, the med student might have elicited the review of systems of polyuria, polydipsia. He might have asked about that. The patient would have then, the student would have said, have you ever taken lithium for your bipolar disease? He said, yes, 20 years worth. Then we would have known.
Right.
Okay. So that's the analysis.
Great case.
That's the analysis of the case. So while we were aggressively trying to replete his water deficit, it should be no surprise that his urine output remained high because of his solute diuresis.
Right.
And with that, Craig, we are done for today.
That was a great session, Alan. Again, I learned stuff and really, really appreciate it. And I'm so glad technically we can make this work because now we can do our 4 or 5 SIADH talk. And there's quite a few.
Paradox.
And the aldosterone paradox, take a nice little stuff. We can do some short ones, and we want to do SGLT2 inhibitors. There's a lot.
Which basically, I just sent you the paper the other day.
Right.
Looks to be a treatment for hypomagnesemia.
Unreal. That's amazing.
Unbelievable.
That's awesome.
So yeah, I mean, so first of all, I want to take a second here to say to our one viewer
yes,
that you have created a tour de force of making this remote technology work. Not only did you provide me with a microphone and a light and a camera that I'm using, and the only thing I got here that's my own is my computer and my underwear.
I probably owed you that from somewhere down the line from the lab. I don't know.
But anyway, you know, I think that we've been able to do this remotely with, I think, an imperceptible decrease in the quality and fidelity. Because of your attention to cameras and lights and microphones. And the only person who did a better job at this when I needed this badly was Aaron Flynn.
Exactly. That guy, he comes back to haunt me every time I'm in a competition.
No, I'm going to tell you this.
All right. Hit me.
I think in this particular area right here, Aaron Flynn is the silver medal.
I think so.
You're the gold.
Hey, man. Appreciate that. Alan, thank you so much. I know your fellows are going to love this one. I'm so happy for your fellows, and I'm so glad that people are enjoying the other podcasts. Make sure you click on them, subscribe, and like the channel because then you'll get notified every time Alan and I get together and talk kidney physiology.
And you also made some easier links to find, because, you know, the Hurwitz Lab does other podcasts, but you've come up with a way to link only to the kidney ones, right?
Yes, I put there. Well, there's a playlist. So if you go to the Hurwitz Lab and you go to playlists, then you can just click on the kidney physiology labs, and you'll see all of the talks, and Alan's name is on them. You can search THL and Alan Segal, and they'll all pop up that way too.
That's good because our one viewer has asked me about that.
Yes, exactly.
You know, do you think, Craig? Do you think as our final thing today? Do you think we're kind of ready for prime time in terms of letting the word out on Twitter?
Oh, I definitely think they are ready. I think, God, we have so much material, and it's so comprehensive. I think it's the time to push the button on that.
Well, I mean, we always said let's do 10. Let's get 10 in the can.
Yeah,
and this is our 10th.
Yep.
But again, you know, this is I feel very lucky and grateful to be able to do this with you.
It's amazing. And I feel honored. I mean, it's like you are the guy with this, and it's so fun as the country doctor and as a guy who takes care of patients. And
well, remember, I mean, it's the college.
that's right.
I got to give credit to the college.
College does do that.
College helped.
Well,
and so we've got some of the ideas we got to pursue, the lithiamide,
definitely,
and these other things we're going to look into. But again, I do think we've done a pretty good job of coming back to go over some of the concepts. And I love being able to throw in a couple of old slides. Callbacks are always good for learning.
Totally.
And I think we've done a decent job of doing that. So it looks like what we were planning next was we'll either do a short one.
I think the SIADH one would be good follow-up to this because we're in that mode right now.
Right. SIADH would be a long form. And then we have the SGLT2 inhibitors and the aldosterone paradox as potential short form.
Yep.
Shorter form. But anyway, this is great. And I'm going to go out to dinner tonight in Portland and have some great seafood and pretend.
Send me a picture and then of your post-dinner, and I'll get a picture of my post-dinner, and I'll put those at the end of the video.
That
awesome.
Sounds great, Craig.
All right, Alan, well, have a great night. Good seeing you.
You too.
All right, we'll talk to you.
Okay, man. Thanks.
Bye.
Bye.